Hi, everyone. I think we'll get started now. Thank you all for joining today's GORCOP webinar, which is the final part of a three-part series on interpreting quantitative G6PD test results at the point of care. Over the past few weeks, we have heard from a few presenters on aspects of point of care G6PD testing and results interpretation. And today we'll be rounding out that discussion with a presentation from Dr. Benedikt Ley on an assessment that was conducted on the reproducibility of the SD Biosensor standard G6PD test. So I just have a few pieces of GORCOP information to start with, and then we'll get into the presentation, and we'll have time for some questions at the end.
Thanks, Amanda. Yes, I'm Shampapal from Path Diagnostic. Hello, everyone. Welcome to the part 3 of the GORCOP webinar series. Now I will introduce today's speaker, Dr. Benedikt Ley from Menzies School of the Health Research, Australia. So Dr. Benedikt Ley is a public health expert with a focus on the diagnosis of G6PD at the bedside. Benedikt is a research fellow at the Menzies School of Health Research, Darwin, and a lecturer at the Charles Darwin University. I have added a link in the chat box, the top one, where you will find the details of his scientific output. So Ben will be presenting today the reproducibility of a novel point of care quantitative G6PD diagnostic. This study demonstrated a multi-laboratory repeatability and reproducibility of the standard G6PD test. The webinar will present the outcome of this assessment and help inform how to interpret the test at the point of care. To the audience, I now request to place all your questions in the chat box during the seminar, and those will be addressed after Ben's presentation. I'm leaving the floor to Ben now. So Ben, please.
Thank you very much for the introduction, Champa. Hello everybody, my name is Benedikt Ley, and as already mentioned, I'm going to present the results of a study where we were interested in the reproducibility of the biosensor from SD Biosensor that we completed a couple of weeks ago. Can I have the first slide, please? So why do we need quantitative G6PD diagnostics in the first place? So in contrast to falciparum malaria, P. vivax forms dormant liver stages, so-called hypnozoites, that relapse weeks to months after the first infection. And in some vivax endemic areas, up to 80% of clinical cases are due to relapses. Now, hypnozoites are metabolically inactive. The group of 8 aminoquinolines are the only drugs currently available or on the market that effectively remove these dormant liver stages from the human host in the course of radical cure. Primaquine is the most widely used 8-aminoquinoline and is given over the course of 14 days in individuals with more than 30% G6PD activity. There are a number of qualitative bedside diagnostics on the market that can discriminate at the 30% threshold. The most prominent one is probably the fluorescent spot test, and you can see an example of the result on the right-hand side in the slide. This test has been in use for over 60 years now. In addition, there are a number of rapid diagnostic tests in the form of lateral flow assays, such as the one you can see here from CareStart, which was introduced a couple of years ago, and then a recent meta-analysis showed quite a good performance at the 30% GSM cutoff level. Can I have the next slide, please? So the current standard radical cure treatment over 14 days results in poor treatment adherence and accordingly low effectiveness. Over the last years, shorter treatment regimens have been introduced that are likely to increase treatment adherence and effectiveness. However, all of these regimens can probably only be provided to patients with higher G6PD activities, above the 30% threshold. These higher cutoffs can to date only be diagnosed by quantitative diagnostics, namely spectrophotometry. Now, spectrophotometry is fairly complicated to perform and cannot provide a result within a couple of minutes. In addition, it requires a well-equipped laboratory. So, in summary, spectrophotometry is clearly not suitable for point-of-care diagnosis in remote areas where many, if not most, of the VIVEX patients present. In addition, spectrophotometry is poorly standardized. Daniel Pfeffer in early May presented his findings from a meta-analysis where he compared spectrophotometry results across different laboratories. And what he found is sort of summarized in the figure you can see on the slide. So he found that when the same controls were measured by spectrophotometry at different sites using assays from the same manufacturer, the absolute results would vary significantly. And this is really not ideal. In consequence, no global definition of 100% G6PD activity exists to date. This has to be established for each population again, and in addition also when a new assay is introduced. So this really is a major setback for the broad rollout of effective radical cure. Can I have the next slide, please? A couple of years ago, as the Biosensor from South Korea first introduced a handheld quantitative G6PD diagnostic that would address these shortcomings. And you can see a picture of the device on the top right-hand side of the slide. The test requires a total of 10 microliters of blood that is added to a lysis buffer. And 10 microliters of the blood buffer solution are then added to the machine. And the machine then presents G6PD activity in units per gram HB, as well as HB readings in grams per deciliter within 2 minutes. The device had been evaluated earlier on fresh blood samples in Bangladesh in 2018 and a year later in samples from the US. When comparing findings to the reference method spectrophotometry, accuracy in the Bangladesh study was around 90% and above 95% in the study from Paul et al. At the 70% cutoff. In both cases, the device showed a very good and positive correlation to spectrophotometry readings. Can I have the next slide, please? Can I have the next slide, please? Okay, I think Amanda's internet is a bit unstable at the moment. Here we go, perfect. So following Daniel Pfeffer's paper, we were interested to see how much the results from the biosensor would differ when performed repeatedly, which seemed essential to us given the very good performance that we had seen in the field in Bangladesh, for example. So in collaboration with Rosalind Howes from FIND, we developed a protocol to assess, for one, how much results would differ if the same sample was tested by the same machine repeatedly, but also how reproducible results would be when the same sample was tested by different machines. So in both cases, we would compare the biosensor results to spectrophotometry using assays from Point Scientific, as well as comparing the HB readings to measurements from a HemoQ. In order to eliminate variation from different blood samples, we used lyophilized controlled samples that were derived from human blood from the ACS in the USA. And we used a total of 3 types of controls, which we called high, intermediate, and low controls. And all of these controls were reconstituted following the manufacturer recommendation, stored at 4 degrees Celsius when not in use, and used within 48 hours. Can I have the next slide, please? So the study consisted of 2 phases, phase A and phase B. In phase A, 10 devices were tested in parallel by the same experienced lab technician who had worked with the biosensor before. This was done in Bangladesh. Each day, each control was tested 3 times by each of the devices, as well as spectrophotometry and HemoQ. Controls per category were from the same lot number. And this procedure was repeated over 5 days. So at the end, we would end up with 200 biosensor results, 20 spectrophotometry results, and 20 HemoQ results per control. So a total of 600 biosensor results, 60 spec results, and 60 HemoQ results. Next, we decided we would then calculate the coefficient of variation as a proxy for repeatability for high controls measured by the biosensor. And only if this coefficient of variation was below 15% would we proceed to phase B of the study. If the coefficient of variation was above 15%, then the study would be aborted and we would report our findings back to SD Biosensor to be seen what could be done about that. If we would continue to phase B, each machine, together with a set of high, intermediate, and low controls, would be shipped to a different laboratory with temperature-controlled spectrophotometry. And the same testing procedure would be repeated there. However, the testing duration would be extended to 10 days, doubling the number of measurements. So at the end of phase B, an additional 1,200 biosensor results, 1,200 spectrophotometry results, and 1,200 HemoQ results would have been generated. Selected sites would have experience in doing spectrophotometry, and 6 out of the 10 sites that we selected had used the biosensor previously. Each site would test samples using spectrophotometry kits from Point Scientific in the USA, as well as the HemoQ that was already on site. And all testing would be done by a single technician who would receive a standardized online training of approximately 1 hour on how to use the biosensor. And as already said, the lot numbers of controls would not differ between sites. Can I have the next slide, please? So we started testing for phase A in February of this year at the ICDDRB in Bangladesh. After 5 days of testing, we found that normalized G6PD biosensor readings across all 3 controls did not differ significantly. The p-value was 0.996. And we therefore decided to pool these results and correlate them with the reference method, spectrophotometry, and HemoQ. And in both cases, we observed a significant and positive correlation. Specifically for G6PD activity, the correlation was very good, with an R of 0.859. We did, however, also find that 6 intermediate results overlap with a total of 122 low results, and all of the respective readings are between the 2 horizontal dotted lines you can see in the figure on the right of the slide. We also identified 2 spectrophotometry readings that were clearly set apart from the other results, and the corresponding biosensor readings are circled. We decided to include these spectrophotometry readings nevertheless, since they were within this manufacturer recommended range. Can I have the next slide, please? Here we go. So next, we created blunt Altman plots to see by how much the absolute values of G6PD activities and HB readings would differ from the respective reference method, spectrophotometry, and HemoQ. And we found that G6PD readings by biosensor were on average 0.5 units per gram HB lower compared to spectrophotometry, whereas HB readings were 1.8 grams per deciliter lower than the corresponding HemoQ reading. The mean differences are indicated by the horizontal dotted lines in both figures. In the center, the area between the red line comprises the 95% limit of agreement. Can I have the next slide, please? And finally, we were interested in the repeatability of the biosensor in phase A. So this box and whiskers plot shows the results per machine stratified per control. Blue, red, and green colored areas indicate the recommended range suggested by the controls manufacturer ACS. Circled results reflect the readings of the reference method, here spectrophotometry. The dotted horizontal lines indicate the median readings across all machines, across all biosensor devices, excluding the reference method per control. Median G6PD readings across all machines were below the recommended range, both for the biosensor and spectrophotometry. Low and intermediate readings, specifically for the biosensor, were quite close together. When calculating the coefficient of variation to determine repeatability and to decide whether to proceed to phase B or not, the mean coefficient of variation for high controls across all machines was 11%, below the set bar of 15%. The study therefore proceeded to phase B. Can I have the next slide, please? We repeated the same analysis for the HB readings. Here, the manufacturer, ACS, of the controls does not provide a reference range, but rather a point estimate, indicated by the blue, red, and green horizontal lines. Neither the HemoQ results, indicated by the circle bars, nor the biosensor measured the same HB concentration. The black dotted lines represent the median HB reading across all 10 machines. Overall, the biosensor readings were closer to the suggested point estimate compared to the HemoQ. However, in all cases, the HemoQ showed a better precision than the biosensor. Can I please have the next slide? So given that our coefficient of variation by biosensor for the high controls was below 15%, we proceeded to phase B. Each machine, together with a set of standardized controls, was sent out to a separate laboratory. 4 of these laboratories were in the US, 1 was in Brazil, 1 in France, and 4 were in Asia. Can I get the next slide, please? So in phase B, we were specifically interested in the reproducibility of the biosensor. Testing was completed in April across all 10 sites. When we compared G6PD activities across the different sites using a mixed effects model, activity did not differ significantly between machines and sites, while in contrast, absolute readings by spectrophotometry showed a significant difference. You can see the respective results for the biosensor on the left-hand side of the slide and for the spectrophotometry on the right-hand side of the slide. Repeatability across all 10 sites for the biosensor were very much alike, whereas they differed significantly for spectrophotometry, with some sites generating results with very small variation, superior to the biosensor findings, and others with much greater variation. Across all 10 sites, intermediate biosensor readings were 0.3 units per gram HB below the low controls, and that was a significant difference. Now, however, this was not seen for spectrophotometry readings, where readings for low, intermediate, and high controls were clearly set apart across all sites, however, not necessarily between sites. Can I have the next slide, please? HB readings, when looking at the reproducibility of the HB readings differed across all sites, irrespective of method applied, both for the biosensor as well as the HemoQ. And again, we saw a marked difference in terms of precision for both assays. Can I please have the next slide? Whenever we did multiple comparisons, we had to correct our level of significance to p smaller than 0.005 because we were doing multiple comparisons. So when we correlated G6PD measurements by biosensor and spectrophotometry, we saw a significant and positive correlation across all 10 sites. The pooled correlation was 0.64, and that was highly significant. However, the pooled correlation coefficient was slightly lower compared to phase A. In contrast, we did not see a significant correlation for HB readings in 5 out of the 10 sites in phase B. Can I please get the next slide? We then calculated the mean difference of G6PD activity and HB reading between biosensor and the reference method. So when calculating the mean difference of readings between biosensor and reference method, we saw a significant difference for G6PD activities. Given the significant variation in spectrophotometry that we had determined earlier and observed across all sites, we calculated the median instead of the mean difference when we combined results for all machines. The median difference was 0.25 units per gram HB, again, with the biosensor generating lower readings. However, and I really need to emphasize this, the differences ranged from minus 2.6 units per gram HB to plus 1.1 units per gram HB, so really showed a significant variation. Median HB readings by biosensor were 1.2 grams per deciliter lower, again with the biosensor generating the lower readings. However, the mean differences across sites again varied from minus 2.7 grams per deciliter to plus 0.6 grams per deciliter. Can I have the next slide, please? And then we were lucky. The log numbers for high and intermediate controls did not differ between phases. So we were able to compare the impact different users would have on the same machine for high and intermediate controls. When we compared repeatability, the repeatability between both phases, phase A and phase B, did not differ significantly. While the mean G6PD activities differed significantly for intermediate and high controls. The pooled difference for intermediate controls was 0.2 units per gram HB and 0.4 units per gram HB for high controls. Again, this was a significant difference. Can I have the next slide, please? And this brings me to the end of my talk. So 4 out of the 10 technicians in phase B had not used the biosensor device before. However, after a 1-hour online training session, the generated results did not differ, by biosensor did not differ across all sites. The biosensor showed a good and consistent repeatability across all devices in both phases. In contrast, repeatability of spectrophotometry was superior to the biosensor at some sites, but not others. We found reproducibility of the biosensor to be very good. Measured G6PD activity showed no variation when the same control was tested by the same user on a different machine. And when the same control was measured on different machines and at different sites, the difference in results showed only a very slight variation. And when the same device was operated by different end users, again, the variation was quite minor. Measured G6PD activities by biosensor and spectrophotometry correlated well and were higher in phase A, possibly due or probably due since spectrophotometry readings in phase B showed a much greater variation compared to phase A. Now, spectrophotometry could reliably discriminate between the 3 control types, high, intermediate, and low. The biosensor results less clearly distinguish between low and intermediate samples. 6 of the 200 repeat measurements overlapped in phase A. In phase B, the biosensor did not distinguish between low and intermediate controls, and in fact, the results were significantly lower for intermediate compared to low controls, and this was consistent across all sites. Since spectrophotometry in phase B distinguished between all 3 control categories, the observed overlap for the biosensor is unlikely to be due to damaged control samples. The HB readings of biosensor and HemoQ differed significantly, with the biosensor readings being closer to the manufacturer recommended point estimate. While repeatability of HB readings for both machines was good, it was slightly better for the HemoQ. Can I have the next slide, please? The study has a number of limitations. The first one definitely is the study has a total sample size of 3 controls. So this clearly does not allow to calculate accuracy of the biosensor. Biosensor and spectrophotometry are designed for fresh blood. In contrast, we use lyophilized samples, and this may have affected the accuracy of the results, with differing effects for biosensor and spectrophotometry. We found G6PD control readings by spectrophotometry and biosensor to be below the recommended range. Unfortunately, the manufacturer was not able to provide further controls from the same lot, so we could not look at this in greater detail. However, in consequence, low and intermediate G6PD readings were very close together in both phases. And since lot numbers for low controls differed between phase A and phase B, this could possibly explain the observed overlap we saw between low and intermediate control readings in phase B, but not to the same extent in phase A. In phase A, HB readings were compared to a HemoQ 301. However, in phase B, the reference method for HB readings differed by site. While most sites used the 301 or 201 model, some sites used different models, such as the 801 model. And this will have contributed to the observed mean difference in HB readings. And finally, testing was done in a highly controlled environment by very qualified technicians who had several years of lab experience. And while the measurement procedure, and this will have sort of improved our findings, the measurement procedure involves two critical pipetting steps, and these may introduce variation when the device is used in routine practice. Can I have the next slide, please? So in conclusion, the observed reproducibility suggests that the biosensor may be a suitable point of care diagnostic to identify individuals above and below predefined universally applicable cutoff activities if, and that's a strong if, these findings can be confirmed in real-world settings, and if the same or other studies confirm the previous reported discriminatory power of the biosensor also at low activities, so that intermediate and yes. The next steps accordingly would be to confirm these findings in a real-world setting, to establish the effective performance, reproducibility and repeatability of the biosensor under real-life conditions in real-life settings. And finally, not least, to identify training needs and develop standardized training materials for the biosensor. Can I get the next slide, please? And this brings me to the end of my talk. Thank you very much for your attention. I would quickly like to acknowledge all of our collaborators. This really was a fairly low budget production. We only provided the consumables to all of the collaborators, specifically in phase B, and nothing else. So the collaborators that I would like to mention are, for one, AFRIMS in Thailand, then the Aikman Institute, and here specifically Ari Winasti, who managed a lot of the laboratory logistics, including generating the SOPs. Ross Howes, who developed the protocol together with me and did a lot of the majority of the logistics. Mike van Fricken, who was also responsible for one of the sites in phase B, and who helped us with the logistics specifically in the US. ICDDRP, and here Shafyul Alam, as well as Golam Kibriya, who did testing for phase A. The Institut Pasteur and Didier Minard, the Johns Hopkins University, of course, PATH, the SMRU, the FMT HVD, and two groups from the Yale School of Health, for one, Sunil Parikh, as well as Amy K. Bay, and not least, of course, my colleagues from Menzies, Rick Price and Daniel Pfeffer. Thank you very much for your attention. And I'm happy to take any questions.
Thank you, Ben, for the wonderful presentation. I would like to take the questions now, but I don't see any question in the chat box. So if you guys have, I see one now from Jane Cunningham. So Jane is asking if you, Ben, if you have said that technicians use the manufacturer's provided sample transfer device, or if they used micropipettes to collect and mix samples and transfer to device.
Yes, thank you. That's a great question. Just quickly on the background. So the device comes with standardized sort of like Pasteur pipettes, so-called ETSI tubes, which are meant to be used for the pipetting steps. And in phase A, ETSI tips, these ETSI tubes were used throughout, and in phase B, ETSI tubes were used as well. So we did not use any micropipettes, but really all of the supplies that are included with the biosensor.
Thank you. Germana has a question. Germana, do you want to just
yes,
ask?
thanks. Sorry, I couldn't find the thing to unmute. Do you hear me?
Go ahead. We
yeah,
can hear
so
you.
just a curiosity. I think, well, first comment is about the results of the biosensor across sites. I think it's pretty amazing. But I have a question actually on the spectrophotometer, and that might confirm the fact that setting up the biosensor is so much simpler. So the labs, is there any correlation between the time the labs have been doing the spectrophotometer and the results that we see in terms of accuracy?
That's a great question. We haven't looked at that yet. It would be really interesting to determine. I think probably more interesting than the time the sites have been using the spectrophotometry would be how many measurements are being done on a per time unit on a regular basis. But I agree, this is definitely something we should look into.
Thank you.
Right. Any other questions from the audience? So I would say.
So yeah, I had a quick question, Gonzalo, sorry.
Go ahead, Gonzalo.
The HemoQ shows great precision for hemoglobin measurement, but across sites, quite a bit of variability, if I remember the slide correctly. It is used often in many sites, especially in malaria studies, as a reference assay. Any thoughts on poor hemoglobin? Any thoughts on, what that might do to the overall G6PD if you're normalizing by that?
I'm terribly sorry, Gonzalo. Could you repeat the question?
Yeah, so the HemoQ is used as the reference assay for your hemoglobin measurement. You then normalize your G6PD activity on your reference assay. Do you know if that might be one of the sources of the variability in the spectrophotometer G6PD result? That might be an analysis worth looking at.
Yeah, so that is absolutely possible. So we did indeed see the greatest variation in spectrophotometry at those sites where we also saw the greatest variation in HB measurements by HemoQ. So there probably is a connection there, and that's definitely, we haven't looked at that yet, but that would definitely be something that we should compare, looking at non-normalized G6PD activity.
Thank you.
Thank you.
So many thanks, Ben, for the presentation and responding to all the questions. A recording of this presentation will be posted following the webinar. So I don't see any other questions, so I'm wrapping up the session now. We are very thankful to all of you for attending the webinar. Thanks, Amanda, for coordinating everything. And with that, I'm closing the session. Many thanks again, Ben. Have a wonderful rest of the day, everyone.
Thank you very much.
And bye-bye.